I grew up in a bit of a gender equity bubble. Let me explain to you what I mean. When I was a kid, I used to spend my weekends rounding with my dad, a vascular surgeon, in the hospital. I knew from the time I was 5 years old that I wanted to be a doctor. My parents instilled in me a very strong sense of equity and equality. I knew that boys and girls were equal. Men and women deserved equity and equality. If I worked hard, I knew that I would be rewarded for my hard work. If I faced a challenge or a barrier, that was because I needed to improve myself. I needed to work harder. I needed to make sure that my knowledge base was secure. And by doing so, I knew that I would be treated as if I was valued and with merit, and as if I deserved to be where I was meant to be because I worked to get there. I knew there were inequity issues in gender. I knew feminism existed, but not in healthcare, because we're scientists, and scientists work on objectivity and facts. We're physicians. We're empathic. We treat our patients equally, regardless of their background, their gender, their socioeconomic status. That's what medicine was to me. Fast forward a couple decades down the road, I finished college, medical school, residency, fellowship, and I'm now a triple board certified hematology and oncology physician. Sitting in a meeting, talking about an initiative that I have spearheaded, founded, and worked my behind off on. And I was told that I could not be the representative for this initiative. And I was confused. The answer came a couple of seconds later when someone in the room said, "Well, Dr. Jain, we just don't want another pretty face out there." And I thought to myself, that doesn't sound right. And I started to look back at the last decade and a half of my life, and I wondered if some of the challenges and the barriers that I was facing wasn't due to the fact that I wasn't good enough, was because I was in a system that put those barriers in places where they really shouldn't be. I started talking to more women in healthcare, and the anecdotes that were shared were very similar to things that I had heard. "Hey, honey, aren't your ovaries getting a little bit old? Shouldn't you be popping out some kids by now? Maybe you should wait for that leadership position until your kids are in college." Or my favorite, "Why on earth would you go to medical school, take a spot from an equally qualified male candidate when everyone knows you're just gonna get married, have kids, and go work part-time or leave medicine altogether?" Now, full disclosure, I did meet my husband in medical school, but that is not why I decided to become a physician. Now, these anecdotes are very powerful, but the evidence that gender inequities exist in healthcare is indisputable. And as a physician, that evidence is really important to me. When I'm presented a patient or a problem, first I diagnose the problem. After I diagnose the problem, I want to come up with some solutions or a treatment plan. And then we implement that plan to find a solution or a cure. Gender inequity in healthcare is a systemic problem, and it needs to be fixed. The time for a gender moonshot in healthcare is now. I want to start with a statistic that I think is really important. Since 2017, over half of medical school enrollees have been women. But we aren't seeing this in our leadership. Around 21% of our professors are women. Less than 20% of our deans and department chairs are women. So if we're seeing more women enter into the medical field, why are we not seeing that representation in our leadership? Now, I could share with you hours and hours and hours of data on the fact that women have been shown to not receive awards as often as men, that qualified women do not receive sponsorship or mentorship as often as men. The NIH published a study showing women receive smaller grants and less grant funding than men. Women are not promoted as quickly as men are promoted. A study by Dr. Julie Silver and her colleagues showed that women, even in fields where there are more women than men, such as pediatrics, women are not represented in authorship in pediatric journals as much as men. Women are not invited to speak as plenary speakers or keynote panelists as often as men. So all that data exists. We know that data is out there. I'm going to share with you a couple of more subtle examples that you may not even know exist. A great study came out of Yale a couple of years ago, looking at two identical resumes. The only difference between these two resumes was at the top, one said John and one said Jennifer. Now, what do you think happened when these two resumes went out? The application was for a science position in a lab. You would think objectively, looking at two identical resumes, that the people would be valued equally. Well, John was found to be more competent, more hireable, more likely to be mentored, and was offered more money, despite the fact the CVs were exactly the same. And this is in a science lab. I want you to picture yourself sitting in a room similar to this one, and you're listening to a moderator introduce some panelists. There are 4 panelists. The first 2 are men, and the second 2 are women. I would like to introduce to you Dr. Johnson, Dr. Smith, Kim, and Suzanne. You have now automatically put Dr. Johnson and Dr. Smith in a different category from Kim and Suzanne, despite the fact Kim and Suzanne are also physicians. They actually wrote the paper that's going to be discussed. But you don't know that. You just know that the first 2 people who were introduced are physicians and the second 2 are on the panel. This is not hyperbole what I'm describing for you right now. Research that we published just last month showed that at a very large international oncology conference, women were more likely to be introduced by their first name than men when presenting at a national conference. And that automatically makes the audience think that there's different levels of expertise. So I just shared with you 2 more subtle types of examples. I'm going to give you a factual example based in research that's more explicit. Medscape came out with a study showing that women, physicians, get paid 80 cents on the dollar compared to men. Now, when you take that over a career of a general surgeon, that comes out to $2.3 million. That's for the exact same amount of work, exact same number of hours work, exact same amount of time away from family, exact same amount of training, exact same amount of same time of outcomes. Nothing different other than the gender. Even in nursing, where there are definitely more women than men, we see this pay disparity. Now, people ask me, well, that's all interesting, but I don't identify as a woman, and I don't work in healthcare. Why does any of this matter to me? Well, it should matter to you, and I'm going to tell you why. The NIH has shown when women advance in medicine, women's health improves. So we should be treating women and men equitably and equally in healthcare, not just because it's the right thing to do, but also because it's what's best to do for our patient population. In the 1970s, women of childbearing age were not allowed to be enrolled in early phase clinical trials. And many women weren't even looked at in observational trials. It wasn't until 1993 when Congress passed a law stating that women needed to be included in all NIH-funded research that started to change. Now just imagine, for decades, the research and the science that we've been using to diagnose symptoms, identify problems in medicine, and treat our patients is based on 50% of the population. And you don't need to be in healthcare to know that men and women are physiologically different. So we're treating people based on 50% of the population. That's a problem. So I've given you a bunch of stats, I've given you a bunch of data, I've talked about explicit, implicit bias, but what's the solution? So in medicine, when faced with an outbreak such as Ebola, we don't talk about solutions 10, 20, 50 years down the line. We talk about bold action plans now. Solutions that make a difference now. The Cancer Moonshot was launched with the explicit plan of expediting how quickly we can start reaching a cure for more cancers by bringing people together, by being innovative, by using scientific rigor to make real changes. So to me, in healthcare, what we need is a gender moonshot. We need to build on the work and networks and initiatives throughout the country that have already been started. There are amazing things happening around this nation working towards gender equity. What we need to do is harness all of these brilliant minds and all of these initiatives and come together to create validated metrics using the scientific rigor we use when we're trying to cure an outbreak or cure cancer. By creating these metrics, we will be able to hold our leadership accountable and, in result, have institutions that treat our men and our women equally and in an equitable manner, because it's what's right to do and it's what's best for our patients. We need to take the same scientific rigor that we use to treat a disease epidemic and apply it to the systemic problem that is gender inequity in healthcare. And that comes with common sense solutions. So we don't need some long algorithm to try to fix this problem. Common sense solutions are as simple as providing childcare at a conference so that a woman who has children can attend. There are all sorts of common sense solutions that exist to try to fix this gender gap, and I'm going to share with you just a couple today. So the first one I always like to state: promote women, quote women, invite women, nominate women. Now, when I say that, that does not mean that you should be inviting women or promoting women who aren't qualified. Tokenism doesn't help anyone. We want to bring people to the table who are the most qualified candidates. It's essential that people mentor and sponsor. And when I say mentor and sponsor, what I mean is looking for people outside of your normal circle. I give the anecdote. It was mentioned in my introduction that I'm the co-chair and co-founder of the Women in Medicine Summit. When I started the steering committee, I thought that I was being equitable. I had people from every institution. I had people from every specialty. And someone called me and said, "You know, Shikha, this is a really great initiative. Have you noticed your entire steering committee is made up of Indian women?" And I said, "No, that's not possible. There's no way. I don't even know that many Indian women." And then I looked and I realized that I had done exactly what I talk about. I had looked within one circle. And so I started to expand my circle and ask people that I normally wouldn't have asked. And we ended up with an extremely diverse committee. So it's really important that we identify our own implicit and unconscious bias and utilize that to make a more diverse and heterogeneous population of people we're working with. Because you may find qualified candidates outside of your circle that you might not have known existed. Advocating for pay equity. This is a very challenging one because it requires transparency and it requires holding leadership accountable and it requires a conversation. And that's a very challenging conversation to have. So this is one that a lot of people struggle with. Advocating for pay equity can be a challenge, but it's important and it's a discussion that needs to happen. Identifying barriers that exist and coming up with common sense solutions. I gave you a couple already. Childcare. Easy solution. A lot of national medical conferences have started doing that now, and more women are attending. And it's extremely important that we work towards fixing the system and not fixing the women in it. Because really, this is a systemic problem. Dr. David Ansel gives this great quote where a woman and a man are walking up an escalator, and you wonder why the woman is falling behind. It's because the woman's walking up a down escalator. Women get barriers put in front of them that we don't even necessarily see. So we need to start looking for these barriers and working towards fixing them. It took a decade from the time NASA was founded to when the first boots were on the moon. 50 years later, we had the first female spacewalk just last week. We can't wait 50 years to achieve gender equity in healthcare. The time for the gender moonshot is now, And we need to treat this like the systemic problem it is and cure the problem of gender inequity in healthcare. Thank you.